So we've talked about the heart and the blood vessels, but I want to spend just this one lecture here talking about the blood itself. And we're going to just include that. We could have included that as part of connective tissue, but I think it fits better here in this unit. And let's start talking about blood with a case. So this would be the case of Abdi. Abdi's 4 years old, and he seems a little bit small for his age. The main complaint is that he's getting tired easily. He's getting fatigued easily. And his mother notices that he's not able to kind of keep up with the other children. When doing things like playing soccer, he gets tired too easily. The mother thinks he looks kind of pale as well. She also mentions that he's a pretty picky eater and doesn't like to eat meat. He does, however, drink a lot of milk, up to about 3 glasses per day. So the question is going to be what might be going on with Abdi that has to do with his blood. Okay, so remember that blood is connective tissue. If you go back to like one of the first lectures we had, and we talked about the 4 different tissue types: epithelial tissue and connective tissue and nervous tissue and muscle tissue. So blood is in that connective tissue category, and it's kind of on one of the extremes, right? You had bone as connective tissue on one extreme, and then you had blood as connective tissue on the other extreme. So remember, all connective tissue has a matrix, usually some kind of protein or fiber, and then specialized cells. So we're going to kind of break down blood into those kind of basic units of connective tissue. So if we look at the matrix of blood, the matrix is really the plasma. And plasma is pretty much everything in the blood minus the cells would be plasma. And so that plasma is going to be mostly water. You can see it's about 92% water. But then there's a bunch of proteins in there as well. So albumin is the most abundant protein in the blood, and it's produced by the liver. And it's used for lots of purposes, but one of the things it's used for is as a carrier molecule to carry things that don't dissolve well in blood, in water. So some hormones are carried by albumin, fatty acids are carried by albumin, otherwise they wouldn't be able to travel through the blood. Then there's immunoglobulins. These are proteins that our body uses to help with immunity, and fibrinogen, for example, for clotting. So there's a lot more proteins in these. This is just giving you a few examples, with albumin being the most abundant. Okay, so besides water and proteins, there's also other dissolved substances like sodium and potassium and calcium and magnesium, and gases like oxygen and carbon dioxide. So those are all floating around. We would consider all of that part of the plasma, because the plasma is everything minus the cells. So on the other side, then, we have the cells, and the cells are broken up into kind of what their function is. So red blood cells are the part of the blood that carry the oxygen, so obviously very important. White blood cells are going to fight infection. And then platelets are not actually cells. Platelets are really fragments of a larger cell called a megakaryocyte that break off, but they're cell fragments, but they're very important for clotting. And if you have too few, then you won't be able to form a clot, and you'll have bleeding problems. All right, so this is just kind of breaking down what I said, kind of in picture form. So let's say we have a tube of whole blood here. That means we just drew it directly out of your vein. And we spin it down. We can kind of separate the cells and the plasma from each other. About 55% of that tube would be filled with plasma, which is the water and the proteins and the electrolytes. And about 45% of that tube would be filled with cells. So let's just kind of, I don't think there's a lot of new information here, but just kind of in picture form what we talked about. So if you look at the plasma, you can see that we've got water, proteins, and solutes like we mentioned, and you can kind of see some of the percentages here of those proteins I was talking about, and some more examples of the electrolytes. And if you come down here to the 45% of the basically what's composed of cells, we've got red blood cells, and notice they are almost all of the cells are red cells. 99.9% of that 45% is red blood cells. So red blood cells are super numerous compared to white blood cells. And we're going to see this again coming up in the next slide. All right, so red blood cells, as we mentioned, are the part of the cellular component of blood that carries oxygen. And they're the most numerous by far. And we'll see, hopefully we'll get a chance in class to take a look at some blood smears under the microscope and be able to see different cells. But what you're gonna notice when you look at the slide under the microscope is it's almost completely red blood cells. I mean, red blood cells are everywhere, and you'll be kind of hunting around for the occasional white blood cell. So as I mentioned, they're the most numerous, more than 99% of the total cell count. Okay, but what's interesting about red blood cells is they have a very unique shape. We don't have other cells in our body that really have a shape like this. Most of the cells in our body are, we've talked about them before, they're either spherical, or they're flat, or they're cuboidal, or they're columnar. But this one has its own unique shape that we call biconcave. Concave means to kind of dip inward, right? So concave would be perhaps something like that. So biconcave means it's concave on both sides. So if you kind of look at a red blood cell from the side, you can see that it's concave on the top and it's concave on the bottom. That's where that term biconcave is. So what that does is it takes a cell that would be quite thick if you look at the edges there, and it makes the majority of that quite small, quite thin. And that's super important for the function of the red blood cell. So we've been learning in anatomy that so often the structure either, you might say the structure creates the function, or you might say the structure determines the function, or the function is determined by the structure. And so here's just another example. If the function of the red blood cell is to allow gases to exchange, so it's going to let oxygen, well, when it gets to the lungs, it's going to pick up oxygen. So oxygen has to move from the air sacs in the lungs, the alveoli, into the red blood cell. And then when the red blood cell gets to the tissues, it needs to allow that oxygen to diffuse out and feed the tissues. It also picks up some of the carbon dioxide. So the purpose is diffusion of gases, oxygen moving in and out, carbon dioxide moving in and out. So when we want something to diffuse, the rate of diffusion is largely based on the distance that the gas has to travel. And so we would want the thinnest possible cell so that the gas has the smallest possible distance to travel so that it can diffuse as quickly as possible. And so that's what we have in this design of the red blood cell. We've got, the majority of the cell is very, very thin, and that allows for quick diffusion of gases in and out. There's also one more benefit to having a biconcave shape. It makes the red blood cells more flexible. Think about having a donut, for example. If you kind of, my daughter has these, for example. She has like foam food. Basically, she's got some fruits, and she's got like pizza, and she's got a donut. And if you take, for example, a sphere, like let's say an orange, and you try to squeeze it, it doesn't really bend a lot. You might be able to get it to squish just a little bit. But if you take a donut and grab it on either end and kind of press, that donut will almost start to fold on itself because it's empty in the middle. And so the same thing happens here with the red blood cell. As it is under stress, if it goes through, let's say, a very small capillary that's basically the same size as the cell or even a little smaller, that red blood cell will need to bend in order to squeeze through that tight space. And this biconcave shape gives it a lot more flexibility and helps it to bend to fit, and then it will spring back to its normal shape once that stress or pressure is released. Once it makes its way through that small blood vessel, it will bounce back to its original shape. So it allows for some bending, some stretching, some changing of shape, some flexibility, and then it allows it to return to its normal shape. So that biconcave shape is really important. So here's just an example of red blood cells kind of marching through a capillary, and you can see at some points the capillary is not much bigger than the width of one red blood cell, and so we often see red blood cells kind of marching one by one in a line. It almost looks like a stack of coins. when you get to the very small capillaries, because there's not room for two red blood cells to really move side by side, so they have to kind of stack one behind the other. So the function of red blood cells we've been talking about is to carry oxygen to the tissues. That's the primary function. So it's going to pick up oxygen in the lungs, and then it's going to deliver that oxygen to tissues that need it. There is also a little bit of carbon dioxide exchange within the red blood cell as well. We'll talk about that in physiology. But much more important for the oxygen component. So now, if your job as a red blood cell is to carry oxygen to tissues, most cells require oxygen themselves in order to make energy, to produce proteins, and to do cellular metabolism. Well, this is another interesting part of the structure of the red blood cell. Because its job is to carry oxygen, it would be beneficial if the cell itself did not use up the oxygen that it was carrying in order to kind of supply its own needs, right? And so that's what we have here in the red blood cell. We actually have a cell that doesn't do anything. It really has no cellular metabolism, or just about no cellular metabolism. Its sole job is to carry oxygen. And so it has no nucleus. It has no ribosomes for making proteins. It has no mitochondria. It has no endoplasmic reticulum. So it doesn't have that cellular infrastructure that could potentially use up the oxygen that it's carrying. It's basically an empty sac filled with hemoglobin, and the hemoglobin is what carries the oxygen. So again, another unique part of the structure that really aids in the function of the red blood cell. So it's able to carry the oxygen without having to use it up to meet its own needs, because it basically has no needs because there's nothing going on inside the red blood cell, just carrying oxygen. The average lifespan for red blood cells is about 120 days, 3 to 4 months, give or take, for the average red blood cell. So your body, of course, is every day making new red blood cells, and some old red blood cells are dying every day. But if you followed one red blood cell from birth to death, so to speak, it would last on average about 120 days. So as I mentioned, the purpose of red blood cells was to carry oxygen. And so there has to be kind of a mechanism within that sac of a red blood cell for picking up oxygen, for carrying oxygen, and then for delivering oxygen. And so the way the mechanism for carrying oxygen requires this molecule called hemoglobin. And hemoglobin is basically a protein. As you're going to find out, just about everything in your body that has a function is a protein or composed of protein. So, but hemoglobin's a protein, and it's what is actually physically carrying, holding on to the oxygen. And it has a quite unique structure that allows it to not only carry oxygen, but also to deliver oxygen. So you see, you've got kind of a dilemma. You want a molecule that has enough affinity for oxygen that when it gets to the lungs, it will pick up the oxygen that is in the alveoli, right? As the oxygen diffuses into the blood, you want a molecule that likes oxygen enough that it will grab up as much oxygen as possible. But here's the problem. When you have a molecule that has a high affinity for oxygen, that means it wants to hold on to oxygen. So what happens when you get to the tissues that need oxygen? Well, if the affinity for oxygen is too high, it won't want to release the oxygen to the tissues. And so you need a molecule that's perfectly balanced so that it has a high enough affinity in the lungs to pick up the oxygen, but it has a low enough affinity that when it gets to the tissues, it's willing to give up its oxygen. So you need a very unique molecule to do that, and that's what hemoglobin does. It has a strong enough affinity that it grabs all the oxygen it can in the lungs, but it's not so tightly bound that it refuses to let go at the tissues. And when we get to physiology, we'll discuss how that is, how that works. Why is it that it holds on to oxygen at the lungs but lets go of oxygen at the tissue level? For now, just learn that hemoglobin is the molecule that carries oxygen. And I also want you to learn that hemoglobin is a protein composed of 4 subunits. So there are basically 4 smaller units that all combine to make one hemoglobin unit. But each subunit can carry its own oxygen. So that means one hemoglobin molecule can carry 4 oxygens. because it has 4 subunits, and each subunit can carry an oxygen. So how is it that each subunit can carry an oxygen? That has to do with this molecule within the protein subunit called a porphyrin ring. So that porphyrin ring is kind of the central component. In the picture here, it's showing one there, one there, one there. So that porphyrin ring that kind of sits in each subunit has a iron molecule at the center. And iron is typically positively charged, meaning it freely gives up its electrons to neighboring atoms. And so in nature, when you find iron, it typically is iron with a 2+ charge. So it's a positively charged ion. Oxygen, on the other hand, typically likes to receive electrons from other atoms. So this makes for kind of a pair, where the iron wants to give up its electron and the oxygen wants to receive the electron. So that causes the attraction between iron and oxygen. So the oxygen is drawn to the iron because the iron wants to give up its electrons and the oxygen wants to receive it. And since since each of these subunits, you can see we give them different names, alpha and beta, and we'll talk more about that in physiology. But because each alpha unit and each beta unit has a central iron atom, that means each of those subunits has an affinity or a draw for oxygen. So oxygen will be drawn to the iron in the center of each of those porphyrin rings, and therefore each hemoglobin molecule can carry 4 oxygens because each hemoglobin molecule has 4 of these subunits. All right, so that was red blood cells. Those were the most numerous, if you remember, more than 99%. Now we'll move on to white blood cells. And as I mentioned earlier, these are important for immunity, for defense, for fighting infection. And we'll get more into that again in physiology. We'll talk about the immune system a bit more so that you can understand how each of the cells are working. Right now, I just want you to learn the different cells and just a small thing about their function to help prepare you for physiology. So in general, white blood cells are going to fight infection. And most of these cells are free-floating in the blood. Many of them, once they leave the blood, they can roam around the tissue. Some of them are kind of fixed in place and not able to move. And again, we'll talk more about that when we get to physiology. But depending on where they are, they have some slightly different functions. So one of their functions is to fight infection. So if you get infected with a bacteria in particular, or a virus or a parasite, these cells will go to action on your behalf and try and contain that infection and try to kill off the pathogens that have entered your body. But more than just fighting infection, white blood cells also remove dead and damaged cells from our body. Cells are becoming old all the time. Cells need to be replaced, whatever tissue you're in, and some tissues more than others are dying and being replaced. Well, just imagine if those dead cells were never removed. Imagine if they just built up and built up and built up over a lifetime. We would be full. We would be busting with dead tissue. And so we need to have a mechanism for clearing away that dead tissue. And the white blood cells are also involved in doing that. So not only fighting infection, but also getting rid of dead or damaged self cells. Now, white blood cells are typically larger than red blood cells. So if you're looking here, this is kind of an artificial picture off on the right. You would probably never see all of these white blood cells in one view in the body. But just for the sake of discussion, we've kind of made this picture. So if you look at the kind of brown circles, the small brown spheres with the kind of the white dot in the middle, they kind of look like donuts, right? Those are the red blood cells. That biconcave shape gives kind of a donut look to it. And you can see how small they are, how small the red blood cells are compared to the surrounding white blood cells. So the larger cells that you see, those are representatives of these different cells that we're going to go through. And so we can break up these, what do we have, 2, 4, 6, these 8 cells that we have here. We can separate into 2 categories based on what their cytoplasm looks like. So if their cytoplasm has large granules in it, and again, when we get to physiology, we'll talk about what those granules are used for, then we call that cell a granulocyte. If the cytoplasm does not have large granules, then we will call it an agranulocyte. Whenever you see A, that means not, right? So granulocyte means it has granules, agranulocyte means it does not have granules. And you can almost tell from looking, like look at this one here, you can see all these kind of dark staining dots in the cytoplasm. That's granules. Look here at this one. See all these red dots in there? Those are granules. Now look at this one. There's almost no granules. There's just a tiny bit, and so we would call that an agranulocyte. Look at this one here. The cytoplasm is much more smooth. Look at this one here. Much more smooth. You don't have all of the dots, all of the granules that you see, and these ones, and these ones, and these ones. So that's what we mean by granulocyte or agranulocyte. So we're going to separate them into those 2 groups, and then we're going to talk about each type of cell in each of those groups. So if we look at the granulocytes first, again, notice how small the red blood cell is compared to the size of a white blood cell. So white blood cells are typically larger. That's going to be the first clue for you if you're looking under a microscope. So I'm going to start by talking about neutrophils, which is one of the granulocytes. And neutrophils are the like if you just separated all the white blood cells and looked under a microscope and counted them, there would be more neutrophils than any other white blood cell floating around in the blood at any one time. So it's the most numerous of the circulating white blood cells. Its granules stain pale, meaning it's not very dark. You can tell that there's some granules in there, but they're not as dark as some of the other cells that we'll see. What's really going to be your clue is this multi-lobed nucleus. So if you see a picture and the nucleus is this, see, and there's 1 lobe, and there's 2 lobes, and there's 3 lobes, and there's 4 lobes, and there's maybe even a 5th lobe. So having a multi-lobed nucleus, that's going to really be your clue that you're looking at a neutrophil. They have a couple of important functions. One is they are phagocytes, which means they are cell eaters. So they will go around and eat bacteria, for example, that enter the body. They can even eat dead tissue from time to time. And they are most helpful at fighting bacteria. And this is kind of the takeaway, I would say, of the neutrophil. Make sure, as far as the function goes, that you associate neutrophils with bacteria. Let that just be a reflex for you. More neutrophils means bacteria. That's a general rule that we go by. It's not 100%, but it's something good for you to learn. When we are checking a blood count, let's say someone comes to the emergency room and they have a fever and some other symptoms, and we're trying to figure out, is this like a serious bacterial infection that I need to give them antibiotics for, or is this just like a viral, cold, or a viral stomach bug or something like that? One of the things that we'll do is we will check a white blood cell count, and then we will check what is the neutrophil component of that white blood cell count. And if the neutrophils are very high, much higher than normal, then we suspect there may be a bacterial infection. So I want you to remember bacteria and neutrophils. Okay, the next granulocyte are eosinophils. You can see they get their name. This eosin means red, and phils means loving, so they are red-loving. And so you can tell that they stain red. They're the only one that really stain this kind of red. And so it should be easy to identify under the microscope. They have maybe 2, or this one almost looks like 3, but 2, this one kind of almost separates here, right? So you've got 1 here and 1 here. So 2 lobes of the nucleus, although I don't think you'll confuse these with neutrophils because they're so red, and that's going to be your key. But I do want you to know two things about their function. They are important cells for allergies as well as parasitic infections. So we don't see as many parasitic infections in America, but when we were in Africa, we would often check an eosinophil count in the blood count, and if it was elevated, that would give us a clue that maybe we were dealing with schistosomiasis or some other kind of parasite. So I want you to associate parasites and allergies with eosinophils. Okay, next granulocyte is basophils, and that means blue-loving. And so you can see that they stain kind of almost a blue or purple color, like a dark blue or purple, and that's how you're going to distinguish it. The neutrophils were kind of pale, a much lighter color, and it had the multi-lobed nucleus. Eosinophils were red, basophils are blue, and it doesn't have quite as many lobes as the neutrophil. So if you're getting confused between basophil and neutrophil is paler and has more lobes to its nucleus. Basophils are also pretty rare. You don't see them very much, so if you're seeing a lot of something, it's probably not basophils. These guys release a couple of chemicals, histamine and heparin. Histamine helps to dilate blood vessels, and heparin prevents clotting, and so that's kind of their function. And part of what they do also when they release their granules into the environment around them is they attract other cells to the area. So they kind of become a herald. They kind of let the other white blood cells know, hey, the problem is over here. Follow my chemical trail that I've left you. Okay, agranulocytes, we'll look at just a couple. We have monocytes. These are the largest of the white blood cells. They kind of have a kidney bean-shaped nucleus, if you kind of see that nucleus in there. And they become phagocytes, kind of like the neutrophils. But these guys become kind of the main phagocytes in the tissue. And when they leave the blood and they enter the tissue, we change their name. So in the blood, we call them monocytes, but when they leave and enter the tissue, we call them macrophages. And macro just means big, and phages means eaters. So they're big eaters. And so they're really important for going around and eating bacteria and eating dead tissue that's been left behind. The next agranulocyte is lymphocytes, and these are also quite important for our everyday immunity. The way you're going to identify a lymphocyte is that the nucleus takes up almost all of the cell. So it's not going to have, those large granules in the cytoplasm like we saw in some of the other pictures, but it's going to have a nucleus that pretty much takes up the whole of the cell, so very little cytoplasm. These are the second most common white blood cells after neutrophils. And these are these cells are made in your lymph nodes. So this is why, for example, like if you've ever had a cold or a sore throat or upper respiratory infection, and you kind of feel, and you say your glands are swollen, it's not really your glands, it's really your lymph nodes are swollen. Because they are producing extra lymphocytes in order to help fight your infection. So there are three different types of lymphocytes, and so I want you to learn these three names because they're going to come up again when we do immunology and physiology. So there are T cells, T lymphocytes, and T lymphocytes are going to attack cells that are infected, typically with viruses. So bacteria are kind of floating around in your blood and your tissue, and the neutrophils can kind of find them and see them. Macrophages can find them and see them and eat them. Viruses are a little more tricky. Viruses tend to infect your own cells. They insert themselves into your own cell. You become the host. So that means they're hidden. They're not kind of out and free floating and just bumping into immune cells. The immune cells have to be able to recognize your own cell as being infected. And that's the T lymphocytes that often do that, and then they are able to kind of kill that cell with the virus inside. B cells, or B lymphocytes, these are the cells that are making antibodies, which are proteins that help us kind of tag foreign cells or pathogens. And then there's another lymphocyte called natural killer cells. And these guys are kind of roaming around looking for abnormal self cells. You can think of one big example would be cancer cells. So if you've got some cells that have mutated and they're no longer normal and they're starting to form a cancer, these natural killer cells are going to bump into them, recognize that they are abnormal, and it's going to kill them, it's going to destroy them. And so if we didn't have natural killer cells, we probably all would have cancer at a much younger age. So those are the three types of lymphocytes you need to know: T cells, B cells, and natural killer cells. And I want you to remember viral infections. We'll kind of talk more about that part in immunology when we do physiology. But for anatomy, I want you to associate lymphocytes with viral infections, especially T cells. But I want you to associate lymphocytes with viral infections, just like you associated neutrophils with bacterial infections. All right, the last of the cells is actually not a cell at all, but rather just a piece of a cell that broke off. We call these platelets. So these are cell fragments, and they also have granules inside of them. And those granules are very useful in promoting clot formation. So you start with the cell. The cells that make platelets are called megakaryocytes. Mega just means big, right? So these are huge cells that basically break off bit by bit and form platelets, as you can kind of see there in the picture. You can get 4,000 platelets from one megakaryocyte. So most of these are circulating in the blood, but some of them are stored in your spleen and your liver in case you need more platelets. All of a sudden you kind of have a backup in your spleen and liver. And the main thing to remember about platelets is that they aid with clot formation. So speaking of clot formation, there are kind of 3 steps to forming a clot. And I just wanted to introduce this now since we're talking about these cells, and when we get to physiology, we'll talk about a little bit more about the process of how it happens. But the first step in clot formation is platelets aggregating together, kind of sticking together, and forming a plug. And I talked about this in the previous lecture of the heart when we were talking about a myocardial infarction and how the platelets, we give people aspirin to make the platelets less sticky so that they don't stick together and form a clot. That's because, as you can see here, step 1 is really for those platelets to gather together and stick and form a plug. And so aspirin prevents that, and that's why we give aspirin during a heart attack. Okay, well, once those platelets begin to aggregate, stick together, form a plug, call more platelets to themselves, stick more platelets, they kind of form a little plug that then fibrin, which is just kind of floating around in the blood, will become attached to that platelet and will become even attracted to that platelet plug. And it'll begin to form almost a net around that platelet plug. And then with the net in place, step 3 would be red blood cells that are flowing by will get caught in the net and will kind of complete and form the actual clot, the permanent clot. So first the platelet plug, then the fibrin forms that meshwork, and then the red blood cells form the permanent clot. And you can see here a picture that's trying to depict what's going on. If the platelets are the little pink fragments and the stringy stuff is the fibrin, and then you can see the red blood cells are kind of getting caught, and you end up forming a solid clot. All right, if we took a, and we'll do this in class, hopefully we'll have some time to look under the microscope at different blood cells. And we will take a look at what you can see in one view. And this is, I like this picture because it's a little bit more realistic than some of the other pictures we've seen. Notice how you have a sea of red blood cells. You've got, I don't know, 50 or 100 red blood cells in this view. And you've only got 2 white blood cells. And that's about right. I mean, you're going to remember 99.9% of the cells are going to be red blood cells. And occasionally you should bump into a white blood cell. If it's stained well enough and you're at a high enough power, you might also see these platelets. They just look like little dark dots floating around as well. So this is what you might see on a peripheral blood smear. And we look at these quite often clinically to help us determine if somebody has anemia, maybe their red blood cells aren't functioning properly, their hemoglobin is low, the red blood cell count is low. And so we can look at a smear to look at the shape of the red blood cells, to look at the color of the red blood cells, and that tells us a bit about what's going on. We also look at peripheral blood smears to check for leukemias, blood cancers. We'll be able to see those pretty easily. And there's several other reasons why we might look at a peripheral blood smear. So it's an important skill to learn and to know what you're at. And again, hopefully we'll have a chance in class to look at some. Okay, so hematopoiesis is the formation of new red blood cells, and this occurs largely in the bone marrow. We'll find a couple other places where some blood cells are formed, like I already told you, white blood cells can also be formed in the lymph nodes. But in general, I want you to think of hematopoiesis as occurring in the bone marrow. We can split hematopoiesis, which is the formation of blood in general, into kind of the formation of specific blood cells. So if we want to talk about the formation of red blood cells specifically, we call it erythropoiesis. And that erythro, again, just means red, and poiesis means to form. So we've got the formation of new red blood cells. And that is going to occur in the bone marrow, as I mentioned. And it requires some vitamins and minerals to really have normal production of red blood cells. So it requires iron. And so people who are deficient in iron will have trouble forming red blood cells. And this gets us back to our case of Abdi. So Abdi does not like to eat meat, and probably the largest source for most people of iron is meat, particularly red meat. You can get it in some darker green vegetables, but kids usually don't like those either. And so if you have a kid that's kind of filling up on milk and not really eating very much meat and not eating a lot of dark green vegetables, one of the dangers is that they become iron deficient. And because the iron is necessary for building red blood cells, if they are deficient in iron, then they will be deficient in red blood cells, or deficient in hemoglobin anyway. And so that will make them anemic. And one of the symptoms of anemia is fatigue, tiredness. You might become short of breath with exertion. And so those are some of the symptoms that Abdi was experiencing. Now, I mentioned that he drank a lot of milk, and in general, milk is good for kids to drink. It's got other good things for them. But if they're getting so full on milk that they're not eating regular food, then that can become a problem, especially with iron deficiency. Okay, in addition to iron, you also need a couple of vitamins, B12 and folate. So people who are deficient in B12 or folate will also have difficulty making red blood cells. And there is a hormone secreted by the kidneys. We give it the acronym EPO. It's called erythropoietin, which, if you can remember erythropoiesis, then you should be able to remember erythropoietin. So when your red blood cells get low, that triggers the kidneys to secrete erythropoietin. Erythropoietin goes to the bone marrow and tells the bone marrow to make more red blood cells, especially when the oxygen levels are low. So remember that hemoglobin is carrying the oxygen, right? So your body is scanning the oxygen level of the blood. And if the kidneys realize the oxygen level is low, then they assume the red blood cell count is low, and they want to fix that by stimulating red blood cell production, or erythropoiesis. All right, if we continue to look at, sorry, this should say hematopoiesis. I spelled that wrong. Okay, so we have hematopoiesis is the general making of blood. Erythropoiesis is the making of red blood cells. Leucopoiesis, get used to that prefix or that root word leuco. Leuco means white. And so you're going to find lots of leucocytes, leucopoiesis, leukoplakia. You're going to have all kinds of leuco in medicine, and it just means white. So leucopoiesis is the formation of white blood cells, and that still occurs in the bone marrow. But it can also occur in lymph nodes, as I mentioned, and in two other places, the spleen and the thymus. So white blood cell production is kind of a little bit more varied in terms of location than the red blood cells. And just like we had erythropoietin to help stimulate red blood cell production, we have another chemical called colony stimulating factors that kind of stimulate these areas to create new white blood cells. When you're younger, the thymus gland is important in producing some of these lymphocytes. And so there's a hormone from the thymus gland that also helps in production. But if you remember these CSFs, colony stimulating factors, that's kind of analogous to erythropoietin. So erythropoietin stimulates red blood cell production, and colony stimulating factors stimulate white blood cell production. All right, now this looks like kind of a big, intimidating chart, and we're going to go through it, and I'm going to point out to you the parts that I want you to know. You're not going to have to learn all of the steps here. On this one, we've already learned these cells, so there's nothing new in that column for you. We're not going to really even learn this one. You'll learn some of those when you get to physiology perhaps, but we're going to kind of stick to the second to last column. And what this is showing you is how from one stem cell, one blood stem cell, we are able to get all of these blood cells that we've been talking about. And so we're going to kind of follow the development of these blood cells from that multipotent red blood cell stem cell all the way down each line to see how we get our white blood cells, our red blood cells, our platelets. All right, so I'm going to kind of show some blown up pictures of this chart, and we'll go through piece by piece. So if we look at the upper section of the chart, we can see that we start with the hemopoietic stem cell. That's going to be the one that can become any kind of blood cell at this point. Okay, and that's going to differentiate either into a lymphoid stem cell or a myeloid stem cell, which is on the bottom. We'll talk about that in the next slides. So let's look at what happens if this cell differentiates into a lymphoid stem cell. Now it's kind of locked in to creating a lymphocyte. It's not going to be able to create granulocytes. It's not going to be able to create megakaryocytes. It's not going to be able to create red blood cells. Now it's kind of locked in to only forming lymphocytes. However, I mentioned there are 3 lymphocytes, right? T lymphocytes, B lymphocytes, and natural killer cells. So it can become any of those 3 at this point. Eventually, it's going to differentiate into, a pre-natural killer, pre-T or pre-B. You don't have to worry about really what's going on in that column. And it's going to lead to natural killer cells, T cells, or B cells. I'll just make one mention of this column here in this picture, is that B cells are what are going to produce your antibodies, but when they become mature and start making those antibodies in the tissue, we change the name to plasma cell. So you're going to see that sometimes the name changes once we transition from the blood to the tissue. So remember B cells, and remember that they become plasma cells. All right, so that is what's going on kind of in the upper part, the lymphoid stem cells. Let's kind of move down to the bottom and say, okay, let's say we don't differentiate into lymphoid stem cells, but we differentiate into myeloid stem cells. So you need to learn both the term lymphoid and myeloid. So myeloid stem cells are going to help us form the granulocytes, for one, and we'll see down below they're doing something else as well. But myeloid stem cells will help us form our granulocytes, right? And you can kind of ignore that column. So our granulocytes we talked about were neutrophils, basophils, and eosinophils, right? So it can become any one of those. And monocytes. They can become any one of those 4. Well, we're not learning dendritic cells this year. And the only thing I want you to know in between this granulocyte monocyte progenitor and the final cells is this column called band cells. So granulocytes, like neutrophils, for example, when they are immature, right, there's a process going on from kind of, infant to teenager to mature blood cell. And before you get to the mature cells, you get what we call bands. And bands are useful clinically because sometimes, let's say I just caught meningitis yesterday, and I'm just starting to get some of the symptoms. my white blood cell count, my neutrophil count may not yet be very high if you just checked for neutrophils. But if you checked for bands, what you would find is I have a huge number of bands because my immune system was just stimulated yesterday because I just got sick yesterday. And those cells haven't had time to mature into neutrophils. So when you check the neutrophil count, it looks normal. But if you check the band count, you'll find that the bands are very high. That means tomorrow or the next day, my neutrophil count will be high. But today, it hasn't. Those cells are too young. They're not mature enough yet to be characterized as neutrophils. So they're kind of immature white blood cells. And so I want you to learn that term, bands, because we use that clinically. We look for bands. If I see a high band count, I assume that you're actually on the verge of becoming very sick, and especially patients that I think are a little bit older, maybe they have some comorbidities like heart disease or diabetes or whatever. I may actually keep them in the hospital overnight because I'm worried their infection is going to get worse, or I may give them IV antibiotics. So looking for that band count becomes important. So make sure you learn the lymphoid and the myeloid, and make sure you learn the band cells here. All right, let's go down to the lower part of this chart. So in addition to the myeloid could give us the granulocyte, monocyte type cells, or it can give us the megakaryocyte, erythrocyte progenitor type cell down here. So the megakaryocyte, so if this differentiates into a megakaryocyte, that's what you get, and you get platelets that break off. That's pretty simple. If it turns into the pro-erythroblast, you don't have to learn that term, then it's going to form a red blood cell, and we call red blood cells erythrocytes, right? Erythro means blood, cyte means red, cyte means cell, so that's a red cell. And I want you to learn, for the red blood cell, I also want you to learn that immature precursor cell. Just before it becomes a mature red blood cell, it's called a reticulocyte. And that's important if, let's say we're trying to determine if somebody is producing enough red blood cells, right? Let's say somebody's red blood cell count is low. That could be because they're not producing enough red blood cells, right? It could be a production problem. Or it could be a blood loss problem. So they're making plenty of red blood cells, but they're losing it somewhere. Either the red blood cells are being destroyed, they're being torn apart, burst open because their shape or size is not correct, or maybe they're bleeding internally somewhere slowly, and so they're leaking blood like into their colon or wherever. So one of the ways that we determine is the problem with a poor production of red blood cells, or is the problem with a loss of blood, we will check a reticulocyte count. If you are losing blood, but you're able to make blood, that means that you're going to constantly be making new blood, right? Because you're losing excess blood. And so the response would be, we'll make new red blood cells. So you're going to be producing new blood cells all the time at a faster rate than normal. That means the reticulocyte count will be high if you are losing blood. However, if the problem is you're not making enough blood, like you don't have enough iron or B12 or folate or some other reason, then your reticulocyte count will likely be low. Because that's where the problem is. The problem is in formation of new red blood cells. So we often check a reticulocyte count in patients who are anemic. So I want you to learn reticulocyte. Okay, so in the end, you've got your kind of multi-potent cell or pluripotent stem cell, and it can become, right, lymphoid or myeloid. And then you have to know the three lymphocytes, which you should already know. And then the myeloid can either become granulocytes. I'm going to run out of space. Granulocytes. Or it can become these other, the megakaryocytes, or or it can become those. And so the only thing you have to know in between are bands. So you have to know the bands here, and you have to know the reticulocytes here. And that's it, really. You don't have to know all the other steps in between. All right, so just to give you an example, if you remember that your red blood cells should be 99% of your of your cells, right? So when you look when you take a peripheral blood smear and you look under the microscope, you should see, full of red blood cells and just an occasional white blood cell. So the first thing you would notice about this blood smear is, yeah, I've got some red blood cells, but look at all those white blood cells. There's tons of them. There shouldn't be, 15 white blood cells in that view. There should only be a handful. The second thing you'll notice is most of those look like they're all the same kind of cell, right? This one is maybe different and this one is maybe different, but the rest of them are all the same. That means there's probably an overproduction of that particular cell. And what you're going to find is that this is that myelogenous precursor. And so one of the blood cancers that we look for with a peripheral smear is acute myelogenous leukemia, or sometimes we just call it AML. And it's myelogenous, right? Myelogenous tells you it's going to be that granulocyte variety precursor. You could also have ALL, I think that's on the next one, yeah, which would be acute lymphocytic leukemia. So that would be that top precursor cell that can become any of the three lymphocytes. And you know that because remember we talked about lymphocytes, they're almost completely filled with nucleus, right, and very little cytoplasm. I mean, look at all these cells. It's almost all nucleus and just a little bit of cytoplasm, right? All nucleus and just a little bit of cytoplasm. So you know that this is lymphocytic. And notice again how numerous the white blood cells are compared to the red blood cells. So you're not going to have to identify these particular, I'm just showing you these for an example of how we use knowing that tree, how we can use that to help us diagnose different problems. Okay, the last thing I wanted to introduce to you was just a little clinical pearl, since especially the nurses will be starting clinicals much sooner than those who are going to medical school. We order probably the most common, other than a urine analysis, probably the most common test that we order in medicine is a complete blood count. We call it a CBC. And we look at red blood cells, white blood cells, platelets, and we look at lots of other things in between. And so I just wanted to, now that you've learned what the blood cells are, I just wanted to help you understand a few of the things that you'll see on a complete blood count. So the first thing we talk about is a hematocrit. So if you remember that first picture we talked about with blood, and we said that it was like 55% plasma and 45% cellular elements. So that's actually the hematocrit. When you spin down, so you just take a tube of whole blood and you spin it down in a centrifuge so that all of the cells settle and pack down at the bottom and all of the plasma kind of rises to the top. What you'll find is that about 45% should be red blood cells, well, and other cells, but remember red blood cells are 99%. So 45% of that tube should be filled with blood cells, and 55% should be filled with plasma. Now there's a range of normal. Not everybody's exactly 45 and 55. There's a range, and that range is 40 to 54. If you're a woman, you do tend to have less red blood cells than a man, and so your hematocrit may be a little bit lower. So we call the hematocrit the portion of red blood cells, of that whole tube, the portion that is composed of red blood cells. And because red blood cells are more than 99% of all cells, we just look at the solid component versus the liquid component, and that's our hematocrit. So it's kind of a quick way of looking and saying, hey, does this person look like they're making enough red blood cells? We can just kind of spin it down and look at the percentage. We can also check hemoglobin levels and find out that maybe you have enough red blood cells, but maybe you're not making enough hemoglobin within those red blood cells. Or if you're not making enough red blood cells, your hemoglobin content will also be low just because your cells are low. So we can check a hemoglobin as well, and that tells us the oxygen carrying capacity. So these two we're going to use to diagnose anemia. I guess I already have that over here. Then the total white count, we can look and see if that is high or low. So if it's low, we might worry about some kind of a problem with your bone marrow, a problem making blood. Some very serious infections, temporarily, they become so shocking to the system that they actually stun the bone marrow, and you actually have a low blood count for several days as a result of the serious infection. So most often we're looking for a high white blood cell count during infections, but occasionally it can give you a very low count. And so we're looking for those values. I think there's a problem in here. This should not be 10 to the 3. Not that any of you are memorizing these numbers, but there's an arrow there. There should be a lot more red blood cells than white blood cells. I think that's supposed to be to the 6th or something. So kind of ignore that 10 power. You don't have to memorize these numbers anyway. I just want you to be aware of the categories. So that's the total white blood cell count. But then I was telling you that we can look at that total white blood cell count and say, okay, how much of those white blood cells is neutrophils, and how much are lymphocytes, and how much are monocytes, and how much are eosinophils. We can actually separate it out and look at the percentages. And we know what normal is. So if we are off normal, so if neutrophils are high, we might be more worried about a bacterial infection. If lymphocytes are high, we might be more worried about a viral infection. If eosinophils are high, we might be more worried about a parasite infection. So we like to split those up and look at the individual percentages as well. And then lastly, we look at the platelets. So if somebody's having a bleeding problem, they have a nosebleed that won't stop, or they're bruising, for no apparent reason, one of the things that we'll check is the platelet count. That's one of the parts involved in clot formation. So you'll see a CBC a lot, and hopefully now you can at least understand the major components of it. Okay, as I said, I hope we're going to have time in class to take a look at some of these blood cells under the microscope, and hopefully that will help you remember the different types of cells.